Welcome back to Optimized Health. Hello, Miss Laura. How are you today?
I'm good. How are you?
I'm good. I am good. I feel like fall's a coming. What do you think?
It is. It feels wonderful in the mornings.
It does. It
Heats
does.
up in the afternoons, but it's great to be outside.
I'm going to wear all my wardrobe at once.
Yeah, exactly.
Yeah,
just a layer. Yeah. Absolutely.
Just for fun. Just for fun. So how have you been without one in the nest?
Well, it's definitely a roller coaster, but I'm learning how to kind of navigate that a little bit, I think. I have one that just started college this year for the first time, so we are one down.
One down, one to go.
Little brother is, enjoying his only child status, I think, for a bit.
Understood.
So, in fact, I need to give a special shout out to his friends today.
Why?
You don't know this, but we have a special group of listeners that always want to play our clips during like group video games. And I just want to say that all those 16-year-old boys out there that love to listen in, we are just so thankful for your support.
Thank you.
And your encouragement. So thanks for listening in to our podcast and for cheering us on.
Absolutely.
Yeah.
I'm a little stunned.
I know, right?
I'm a little stunned.
I know. I had no idea we had such a following.
Well,
but, hey, we'll take it, right?
Yeah. Who's our guest today?
We are very honored to have Dr. Chris Sanborn with us today. He's the director of the Erlanger Metabolic Center. And so they provide both surgical and non-surgical options for weight loss. And it is definitely the hot topic of today's culture. It is not a day that I go into the clinic that I don't have the complaint of weight gain and have to deal with that myself and through the menopausal transition. I know, Mandy, you and I both work really hard to prevent that in our lives, but, so I'm just thrilled that he can join us today to give us some insight about the obesity epidemic and the difference between being overweight and obese and some of those options that our patients may want to look into, if the non-surgical route is failing. So welcome, Dr. Sanborn.
All right, thank you. Yeah, glad to be here. Thanks for having me.
We're glad to have you.
So if you will, I always love to start with just understanding why someone went the direction they did in life, because I'm sure you had many options in medical school as far as what path you wanted to take. And so can you tell us a little bit about your history, just how you got to the role you're in now?
I went to medical school at University of Tennessee.
Okay.
And had always wanted to be a doctor. I did have some kind of plans for maybe research and everything, but I always kept that door open. And so I went there. Didn't really know exactly what I wanted to do, like most of medical students, between medicine and surgery. And ultimately found that surgery was basically the best balance of everything. Because as a general surgeon, we were able to do the surgery and still even medically manage our own patients and stuff a lot of times. So I went from there. That my residency was actually at Madigan in Tacoma, Washington. That's at Fort Lewis. Mm-hmm. And so I was there for about 5 years and then went to Fort Campbell. Now, when I was at Madigan, we did a lot of bariatric surgery there. That was open bypasses. So I'm old enough to have done those.
Wow.
So we did a lot of those there. At Fort Campbell, you had a lot of healthy, active duty folks, but you also had a lot of dependents and retirees. And so, the obesity problem, we still had that there as well. And there was a need, to help out with those folks. So we started doing the bariatric surgeries there. And I started, doing a few open bypasses, and then we converted to laparoscopic. And then after about 8 years there, I ended up down here.
That's awesome. How long have you been here now?
I've been down here about 15 years.
Wow. And always in the metabolic health arena, right?
Right.
Okay.
Right. Yep. At Erlanger the whole time.
Wow.
Yeah.
That's great. Yeah. I've had several. We've had a lot of shared patients over the years. You don't know that, but we've had a lot of shared patients who've had
your name on a lot of charts.
A lot of great success. And so, but we'd love to get into the surgical options, and I want to do that. But before we do that, let's start with just talking about how does a patient get to you? Tell us what type of patient that you see. Is it someone that's been working on weight loss, or, how do you determine, is this a right surgical candidate? I want to get into all those topics today. So start us off with how would you, when you first see a patient, kind of what's that process like?
Yeah, so patients get to us a variety of different ways. Sometimes they're referred by a physician. They've talked about those problems and decided that would be something good for them to look at. They may find us on their own on the internet, searching through and looking, for somebody to help with their weight and everything. We do have webinar that's on our website that they can watch and get an idea of some of the things that we do. And then we bring them in to kind of see what it is they're really looking for and try to tailor things for them. And a lot of times I end up, talking to the patient about, well, what is it that you're looking for here? Now, if they've been doing a lot of medical stuff and that's been failing and it gets a little bit more obvious, we're looking at surgery and everything. Sometimes it's like, are we looking at medicine, or you just want help?
Right.
And for the most part, they just want help, right? And so we can go through and kind of see what they've done before and what they're open to. And then, we can go down one or both, or either just medicine, surgery, let's try medicine first and then we'll hold surgery back. Or it's, we're beating a dead horse and it's just time to operate, right? I mean, because they've tried everything under the sun and everything. But yeah, we have a lot to offer. So we want to make sure that they're open to everything and have looked at everything.
That's great. So I'm sure you've seen that evolve over your time at Erlanger, from, like you said, the open cases to the laparoscopic. And then tell me kind of like, what are your surgical options now? Like, tell us what are the most common ones and kind of walk through that with us.
Sure. So, historically, the Roux-en-Y gastric bypass has been kind of the gold standard, really. That's not to say it's the best one for everybody, but it's been around the longest. It's the most studied. And so you have to compare everything to that. So obviously we offer that. We also offer sleeves. Sleeves relatively newer, but it's been around for a while now, too. That's our other main option, is the sleeve. And so we have to kind of help the patients kind of decide between those things. Now, there are a lot of other things that you can do and a lot of variations of these. The lap band, believe it or not, is still out there.
Yeah. I know a few people with that.
Yeah, you can argue whether, anybody should really be doing them anymore or not. It hasn't worked out that well for everybody. Every now and then I run into somebody who's doing well with one, but the experience with those was not what I think would keep people doing those. And that's why you see something that, when you had bypass out, right, it was like the thing, right? You had open bypasses, then lap bypasses and everything. And then you had the group of people that really didn't want surgery on their stomach. They didn't want surgery on their intestines, and they came out with the band. Okay. And so you had those two options, two big options. The band was so minimally invasive, right? Come in, get it, go home, get some, a fill of the band, you inflate that balloon. Yep. And it seemed like, there's not a lot of downside. Well, over time, we find out it didn't work that great because it's just restriction.
Okay.
And there was a lot of reoperations because we were taking them out, for problems associated with them. But in between all that, the sleeve came out, right? Okay. And so the sleeve is like, we're just taking some stomach out, making a smaller stomach, and now you had something that seemed like a happy medium in between, right? Okay. You didn't have to do the rearrangement that we see with the bypass, and we can talk about that more if you want a little later on here. But you didn't also have a foreign body in you. You didn't have a piece of silicone or plastic or however you want to think about it in you. And so you had that one. And it seemed like a great operation and it still is a great operation for a lot of people, but it was kind of deceptive. We think about how simple it is. We're just taking out most of the stomach, 70, 80% of the stomach, kind of leaving it like a small banana shape.
Okay.
And so you think everything's going through the normal route and everything. So, at first, most people didn't think you had to worry about vitamins or malabsorption and those kind of things. But over time, we found out we do. We also found out there's some reflux issues with it. So it's something it's good, but it's to be respected. And so that's why the bypass has never really gone away.
Okay.
In fact, you're probably seeing a little bit more of a resurgence of it. But I also said there's some other things out there like the duodenal switch. Okay, it's a little bit more complex operation. Bypass a lot more bowel, so there's more malabsorptive issues with it, but it's a lot like the configuration of a bypass combined with the sleeve. And then now we have these, what we call single anastomosis, duodenal switch, single anastomosis, gastric bypass, just different ways of doing the same thing without having to do the second connection that we usually have to do with the intestine. And that's kind of out for debate on whether those are ultimately going to be better, the same, or something that we need to continue on with. But those are kind of the hot new things right now that, as insurers start paying for them, you'll start seeing more of those.
Okay. So Because our listeners are not surgical, and I'm not as well.
Me either.
Let's talk about this in terms of, okay, so band is at the, where is that placed?
Yeah, band is placed at the top of the stomach, basically
Okay.
in the bottom of the esophagus. Just right at the top of the stomach. So I don't know if we can see it on here or anything, but if my thumb is like the esophagus
Okay.
come down to the stomach, band's placed right around there. And
Okay.
that's kind of the problem, right? You're kind of adding something that's created to basically be an obstruction to food going through there and slow it down, fill up a pouch, and then you would feel full and not eat as much. Well,
Okay.
the problem is, think about wiring your jaw shut. Seems like that ought to work for weight loss, right?
You would think. How's it going in?
You
We'll
can't-
find a
can't eat
way.
as much,
We'll
right?
find a way.
but think about it. Where are we? We're in Chattanooga. So, what's
Right.
the number one drink? Probably sweet tea. Right? Or
For
soda.
sure.
So, whatever you want to pour through there. Chocolate shake, you can get the calories in. And the hunger's not going away. So you saw some pretty interesting maladaptive eating disorders with that on trying to get liquid calories or what we call slider foods and things like that down through there. So that's where it's at. And then also over time, what we see is when the esophagus has to work that hard to push things through there, the esophagus kind of wears out a little bit. And so we kind of see this dumbed down esophagus over time. I'll see patients that come in, they've had a band a long time ago, and it's so dumbed down you can't tell what's going on, right? I mean, because they'll be like, I'm eating more than ever and everything, and I need the band tightened. Well, you look, and the band's so tight and hardly anything's going through, but the esophagus is really big and dilated, and it's just not functional.
Okay.
And
Oh,
so
that's-
you end up having to kind of break the news. It's like, I actually need to take the fluid out and probably should take the band out. Okay, sometimes you can take it out and rest it and go back and try to manage the band. But it was difficult in the first place. It's going to be difficult again.
Okay.
So the band's a little tricky. It seems simple.
Yeah.
But
It
when
does
we're-
seem simple.
When we're trying to finesse an obstruction of an
Right.
organ, doesn't always work out real
No,
well.
it's not designed to do that necessarily.
Yeah, and
so
if you look through the history of surgery, there's been other times where we've put things around that area and didn't work out real well. And we kind of relearned that again and again.
Sounds like your body fights back.
Well,
It's like, oh yeah, watch this.
yeah.
Exactly. Well, and that's the whole thing with obesity, right? There's so many different factors in there,
Right.
and you might hit on one of them, and other ones will compensate for that. So that's what makes
Right.
it so difficult.
Yeah.
It does. And so then the sleeve, you're actually taking a portion of the stomach. Is that right? Did I say that right?
Exactly.
Okay.
You're taking about 70, 80% of the stomach. I mean,
Okay.
you can debate the exact percentages and everything, but what you do is you take it from the full stomach size to basically something that looks like a tube.
Okay.
And we do spare the end of the stomach. So I used to say it looked like a banana. It looks like a banana with a light bulb end, basically. So it's a lot smaller. And because it's based on the lesser curvature side of the stomach, that kind of smaller side of the stomach, it gets things through the stomach quicker too.
Okay.
And so we talk about sometimes the hormonal changes with surgery with the bypass and everything because we're putting that food in that small bowel that's not used to seeing it so quickly. And we get that GLP-1. I'm sure we'll talk about that a little bit later
Yes.
too and everything. And you get those hormones that go up. Well, when you get things through the sleeve a little quicker, you kind of get some of the same effect.
Okay.
Okay, and there's some hormones that we think are made in that stomach, like ghrelin and everything.
leptin.
When you take that out, you can see that decrease.
Okay.
It's a little debatable about whether that's actually responsible for the weight loss or that's just something we see with all that. But you're doing some hormonal things with it. So it's not just you made it smaller.
Right.
You've changed the way the hormones are responding to the meals.
Right.
That's interesting.
That is so intriguing. I was reading about that before this just to prepare a little bit. So I actually sounded like I knew a little bit about what I was talking about.
Me too. Yeah.
well done, you.
Yeah. But, you think the anatomical, obstruction, and then we had a little bit of like hormonal shift when you remove some of the stomach. So then walk me through the next option after the sleeve.
Okay, so we talked about the band, we talked about the sleeve, we're talking about the bypass.
Okay.
So the bypass is one of those ones that's really tricky because I think even for surgeons, it's been, we learned over time, right? It was thought that we make this pouch out of the top of the stomach, and then we reroute the bowel. So now food comes down through the esophagus, into that pouch, and then into the small bowel. And I think over the years, we've really overemphasized that pouch thing. And we probably should just get away from that and just say it's just conduit. We're just making the esophagus a little bit longer so we can make that connection a little bit safer. And all it is taking the food and just dumping it right into the small bowel. And that small bowel has been much further down before, right? This is one of those things that's hard to do with my hands here.
Right.
We've taken it. We brought that bowel up here to a pouch, right? So that when it usually sees it, let me go back a second, just talk about the way that some of the hormones work, okay? There is a theory called the ileal brake. So the ileum's like the end of the small bowel right before it enters the colon, okay? And if you get food down to there, okay, it is sensing food and it says, okay, fine, you've eaten enough, it's getting down to me, I got enough to process, you can stop eating now. And so that's when we start seeing those hormones go up. It's almost like the old Lucy and Ethel candy wrapping.
Oh, yeah, where she's shoving it all in her mouth.
Right, yeah, you know, it's okay for a while, and then it gets overloaded, and then they go hit the stop button, right? Well, this, when we do with this, it's just like dumping a bunch of it right in front of them, and they hit that stop button hard, right? And so that's when you see the GLP-1 levels go up and everything. Ghrelin levels may actually go down from bypassing that stomach. Okay, and there may be some other things about bypassing the early part of the duodenum, that first part of the small bowel, but essentially that's what you're doing there. The whole concept of the pouch doesn't really work when you think about it. Yeah, you're not going to eat a big meal, but again, same thing with the band and same thing even with the sleeve on a restrictive. You're only restrictive to big, chunky things, right? To liquids, you're not as restrictive. So you can still overcome it if it was just that. But the hormonal part's the key of those surgeries. And then if you want to round it out with the duodenal switch, duodenal switch is like a gastric bypass, but it's like you did your sleeve first and you bypassed up to the first part of the small bowel, so just after the stomach. So some people think there's a valve within the stomach. It's called a pylorus, right? And that regulates emptying of the stomach. So some people think that that's very important in decreasing weight regain and everything because it eliminates some of the dumping that we see, right? So it kind of holds things in the stomach, lets it out a little bit more slower, a little bit more physiologic in that sense. Okay, the problem is you still have some of the reflux issues and stuff, but the historic problem with that has been they bypass so much bowel that there's a lot of malabsorption. Not just for some of the micronutrients, but macronutrients as well. And that was a little bit harder to keep up with. So that those patients, tended to eat a lot. And if they ate the wrong things, they got a lot of gas and a lot of diarrhea from that malabsorption. So it was not always the most pleasant one.
Right.
And then the other ones, the single anastomosis ones, they're also called like a loop duodenal switch or a loop gastric bypass, mini gastric bypass, a lot of different names. And that's just basically bringing the loop of bowel up and not dividing it and then reattaching it. And there's a lot of different arguments on whether that's a good thing, bad thing, or otherwise. So
which one, I know you said this earlier, but just to recap, which one are you seeing the most done now, like as the first option?
Okay, I'm going to say we're a little bit of an oddball. Okay, because if you
I like that.
You go across the country and you see sleeves are the predominant. And a lot of it is because of that conceptually, you look at it, it looks the simplest. It's touted as being the less invasive of between that and the bypass, your two main options, right? And it's not really, okay, because of those reflux issues, reoperation issues, and a lot of times conversion to bypass to fix the reflux. They're pretty close in terms of short-term and long-term risk and everything. So, but I'm sorry, I just got myself off track.
I was just saying, which one are you now as first option?
So we do. So because of that, and because of what we've seen with the reflux, and we're very picky on patients that come with reflux, is very common with reflux and hiatal hernias. We do. Actually, we were just looking at this morning. Bypasses probably about 4 to 1. To sleeves. So sleeves are still good, operation. They're still good for one really special group of people that cannot give up their NSAIDs or their steroids. Okay, so those folks are a little bit better off with the sleeve because they're probably not going to get ulcers with the sleeve. It's not guaranteed, but they're probably not. But with the bypass, it's going to put them at a lot higher risk for ulcers. So if those medications can't be given up, maybe a patient with lupus that's intermittently on steroids or has to take NSAIDs or whatever, something like that, then, sleeve's probably a better option for them.
Are there changes before surgery, like dietary changes or restrictions before surgery to because what I'm hearing as far as like acid reflux and things like that is there's going to have to be, you can't just go right on out and eat whatever you want right after surgery is what it sounds like. But is there a practice run, for lack of a better explanation, ready, set, go before surgery, in terms of
pre-op type?
Yeah, like food, to retrain.
Plan.
Yeah.
Right. Well, from the get-go, they start working with the dietitian. and
That's awesome.
start working on
That's
changing
very
the
good.
eating habits and everything. Now, what they are right before and right after surgery is different than what it is, for a lifetime, right?
Okay.
But we do start working on, changing those macros and stuff. And we do tend to go towards a lower carbohydrate, higher protein, higher fat diet.
Okay.
Now, before surgery, for a couple weeks before surgery, we try to get them on what a lot of people call the fat, the liver shrink diet and that kind of stuff. Basically, it's a low carbohydrate diet. And to give us no secret, what it really is. It's like 3 shakes a day and a lean cuisine meal.
Okay.
And it's that easy for the first week. Second week, we drop the meal, we add in another shake.
Okay.
During that time, they're going to lose some visceral fat. That will help make the surgery go better. And they will decrease that weight and size of the liver so we can move it out of the way and operate on it. But that's usually, most people think it's defatting the liver, but a lot of it's deglycogenating the liver, because obviously when you go on a low carbohydrate diet, that's one of the first things you're going to start mobilizing.
Moving it out of the
is that
stores.
glycogen.
Yeah.
Yeah.
And it's, I like that you brought that up, because I think for our listeners, visceral fat is so much more inflammatory and pathologic than subcutaneous fat.
Right.
So
right.
when in your practice, when you have one of these surgeries, are you addressing both? Are we removing or lowering visceral fat and subcu fat?
Yes.
Which is awesome. Yeah.
And it's an interesting thing. You lose both, and we do, occasionally have to reoperate. Maybe take a gallbladder out, maybe take care of another problem in the future. And one thing you notice is that regardless of whether they've had any weight regain or not, a lot of times that visceral fat remains less than it was before. Let's say like somebody had a sleeve, right, and they've lost weight, maybe even gained some back, but we're doing a conversion for reflux to a bypass. You go in and that bowel, you can move it around. Usually worried about reaching up to their, the top of the stomach. You could probably put it up at their neck. I mean, it's that much more mobile. So I think, and this is anecdotal on my part, I don't think it's well studied, that a lot of that visceral, fat, we get rid of that. That's even more persistent than the subcutaneous fat.
And so when you're in there operating and you see the liver, you're able to actually visualize that fat lower. Have you yourself seen that? Because I think that's intriguing. We think about non-alcoholic fatty liver disease,
right,
being such a leading cause of chronic disease, liver failure. And so are you able to visualize that change?
Well, sometimes, the first time we're in there, right, we didn't
Right.
see it in the first place.
Sure.
So we don't
Yeah.
really know. People have looked with ultrasounds before and afterwards, and they certainly see objective changes there. People we've operated on and come back from another operation like that, we can see that it's easier to move the liver out of the way. But, you're not going to remember that far back.
Right, yeah.
But it certainly does. And that's the interesting thing, because we used to think it was a one-way path, right? Catch them at fatty liver before the cirrhosis, or you're not going to, maybe you stop it from progressing, but it's not going to get any better. Well, in actuality, there's a study showing even cirrhosis will repair itself with weight loss.
Wow.
It's never 100% for anything, right? But I mean,
Right.
that's a significant thing, because that was always thought to be kind of a one-way street. You get to
Doomsday.
cirrhosis and you're just hoping to stop progression.
Right.
But actually you get regression of it, with weight loss as well. So
Wow, that's intriguing. So then after a patient has one of the procedures, bypass, in your instance, what is the recovery process like? And what do we see at 12 months out? And how long do you follow those patients?
Well, first off, we follow them as long as they keep coming back, right?
Okay.
So we want them, I've been in 15 years. I get patients that are, 15 years out now. I got a lot of patients 15 years out that are not, right?
Right.
People do what they do, and then they
Sure.
go on. And, by the way, if they're listening, make an appointment, come back and see us and show us how you're doing, right? And
Yeah.
So, but no, we want them to come back because, things advance. We find out new things. We want them to be, to benefit from it. If they're having problems, we want to be able to help them with that.
Right.
Right. So when you have surgery, you come in, you have surgery. Usually you're in the hospital for a day.
Okay.
Probably about 80% of the patients get out at one day. The rest get out 2 days. Very long.
Okay.
Very rare to stay a little bit longer than that. Then we see them back in a week. Okay. Most patients are driving by the end of a week, as long as they're pain-free and off their pain medications and things. Back to work at a desk job in about a week or two. We try to encourage them to take that week or two because
Sure.
You gotta
used
heal.
to
Surgery.
getting used to a different diet. It's not just incisions,
Yeah.
right? So there's a lot of
Right. A lot
different
of
things
mental
going
energy.
on.
Yeah.
Right?
There's some changes.
So that sip sounds really simple, but it takes some work sometimes.
Sure.
having to lift and things at least 3 or 4 weeks, for those, if that lifting is a big part of the job and everything. Then we actually have the patient see the dietitian when they come back in the first week. They see the surgeon, the dietitian. They'll see the dietitian again at 6 weeks and 12 weeks as they're kind of transitioning to, I don't want to say regular diet, but regular textures would probably be better, right? Because, the question always comes up, when will I be able to eat normal?
Yeah.
Right? And I was like, well, why would you want to eat normal?
Yeah.
Please explain your new normal to me.
This is a new normal.
New normal.
Exactly, right? Because the old normal wasn't very good for you.
See what happened
So
when
if we do that, we've seen what happens on that diet. And that's truly what happened. You go back to the same diet, the surgery's going to get real limited what's going to do for you.
Yeah.
So a lot of this is just getting to this new normal diet. It's not I lose my weight just like any diet, right?
Right.
I lose my weight and then I go back to eating this.
It's a lifestyle. It's a lifestyle pattern.
Are there support for like family and maybe just, I can imagine there being like, anytime I change my diet, I have a tendency to go to muscle memory. Like whether it's, I eat a bag of chips or whatever, and I'm like, oh crap, that was muscle memory.
Like what you used to do.
Yes.
Like your old patterns.
I know better, but that was, that was my old pattern. Or in a weak moment or, something like that because food tends to be an emotional thing for a lot of people. So are there, like support where you're like, I don't know if your nurse handles that for you and where they're calling and saying, help me, I'm having a moment, or, or a husband's calling going, I don't know what to do with her. Like I've got menopause and this, so I'm just curious if there's, just an extra line of help, or are you getting bombarded with all that?
All that's a thing, right? All the above, right? Do we have support? We have support groups. Okay, we do support groups. We do encourage the patients to bring their families with them when they come, especially significant others, those closest to them. You do see. It's kind of funny. You see a lot of different effects. One's a very beneficial effect, right? They're trying to. Some of the family, we're going to do the same thing,
right? Like a trickle down,
that kind of stuff, or halo effect, right? So you do see some overall weight loss in others in the family. You also see some people getting kind of hungry because,
they're starving me to death.
Mom or dad used to do the cooking there, and then all of a sudden they're not because it's not really, or it gets to be challenging if they're cooking for the rest of the family, but they're eating different. So there's a lot of adaptation. I don't think there's an end to how much support you can try to provide, but you got to get people to take part in it for one thing.
Yes.
And then there's also at some point there's limitations and resources and everything. So you keep trying to find what you can and keep trying to encourage what you can, but it is something we talk about all the time, that to recognize it's bigger than just this, right? It's bigger than just you doing this, that the whole family, it plays a role positively and negatively sometimes, right?
And I'm sure you're seeing so much of the health aspects, the positive health aspects, just from losing that visceral fat, just the trajectory that patient may be on for diabetes or heart disease or, cancer or, all the things that we know obesity puts us at risk for.
Right.
So I'd love to hear now, and maybe we could switch roles just a little bit and talk about the GLP-1s. I know that and I want to come back to the surgical in a bit just to hear some of your success stories and those patients that really stick out in your mind. But tell me your thoughts around the GLP-1 medications.
Yeah, it's a great thing, right? I mean, if you take the medications we have before the GLP-1s were used, and we took the average weight loss for all of those and combined it all, it was about 7%, right? It was, in terms of what we're used to, the comparison between, surgery and non-surgical, it was kind of dismal, right?
And those had side effects as well,
right? We used to talk about 10% weight loss. Benefits, you see slides all over the place, benefits of 10% weight loss. And we were having a hard time achieving that with medications. I don't know if you remember when Lorcaserin came out.
Yes.
It's off the market now, right? It was kind of the new fenfluramine, basically, that wasn't going to have the bad effects. Well, you find out differently over time, and everything. But when that came out, we started talking about 5%. Well, what it achieved about 5%.
Wow.
So,
Yeah.
Go figure.
Right. Why did we talk? Yeah.
So anyways, so we've gone from that to talking about the GLP-1s. Now you're talking 15, 17% or better, right? You're getting in that same air with surgery. Surgery is going to be up between 20 and 30%. Now you're getting 15, 20% or whatever, depending on the person in the study and everything.
Right.
So suffice to say, it's a lot better, right?
Yeah.
And so, as a surgeon, right? I mean, did you just watch all your business walk out the door, right? I mean, you gain something else you can use,
Right.
Because like everything, there's not a one
size fits all.
There's there's no magic pill,
Right?
Right? All those
Believe it
kind
or
of
not,
things.
there's no
They're
magic.
not just tried expressions; they're true,
Yeah.
Right.
But it's good. It's probably going to be good for a lot of people and everything. And it complements what we do.
Yes.
We get weight off some people, get them ready for a safer surgery. We use it on the backside if there is, problems with weight regain. Right. And so, it's just become another tool. Now, the good thing about it, or the great thing about it, which I'm most enthusiastic about, is that now a lot of your primary care providers and a lot of your patients, doctors that they see on a regular basis have a tool they can use too and see palpable results with, right? So now there's a lot more interest in treating obesity.
Right.
And so I think that, this is one of those whole thing, rising tide raises all ships. And so, surgery's not going away. Okay.
Right.
Almost every patient I see in the clinic has been on one of those GLP-1s.
Really?
Interesting.
So, but does it put a dent in the overall numbers? Sure, palpably. You look around the country, less surgeries going after they were just skyrocketing for a while, and then it's like boom. But with the increased interest, we're going to see a lot more. We've always talked about we operate on less than 1% of patients that would qualify for surgery. Well, there's a lot of room there, right? So we weren't even scratching the surface with what we were doing before, and now you're getting increased enthusiasm overall and everything. So it's surgery's not going away; it's here to stay. The medicine doesn't look like it's going away anytime soon, which is good.
Yes.
Okay. You never know what's going to happen 5 or 10 years with the medication, but it seems to be good. It's been used a lot longer than that with diabetes, right? So we do have some track record. I have some questions in my mind about the level of GLP-1 activity and everything because we have GLP-1 activity increase with bypass, like we talked about.
Yeah, you said
and
that.
even the sleep to a certain extent.
Yeah.
And that's kind of physiologic, and that's a response to meals. So you kind of get that bump up, and it kind of comes back down. Now, with the medications, you got probably 10, 20, 30 times that bump, and it stays up. So what does that do over 10, 20 years? I don't know, but we live here and now, and we're trying to help people here and now.
Right.
So while we need to keep an eye on the things and study those things, we also need to help people. So they're good drugs, and obviously we use those in the clinic too.
That's awesome to hear. Why do you think, and we deal with this in our clinic too, why do you think there is stigma around those drugs and the usage of those?
Well,
That's a good question.
because a lot of people look at that as cheating.
Yeah.
I think that, honestly, and, there's a lot of people that think they know a lot more than they do. They don't give their genetics enough credit that they're not struggling, because not because they're so smart and they know when not to eat that. Think about it this way, right? 10 extra calories a day, put on about a pound in a year. 10 extra
10 calories.
One potato chip.
Yeah.
So if somebody thinks they're smart enough to stop eating when they hit that one potato. Nope, I don't want to do that. I'm going to gain weight, right?
Lay's says you can't do that.
That's right.
You can't eat just one.
You can't just eat 10 calories. You're going to gain a lot.
What they put in it.
Yeah, Lay's will probably sue me for saying that because it's obvious that you will gain weight with Lay's, right?
100%.
Yeah. So but anyway, so I think that's one of the reasons because a lot of people give themselves so much credit for knowing and being able to in such control. And there's some nice studies out there that show the wide variation, how much control you can have, no matter how hard you try over your weight. Some people, some actors, you've seen it gain a lot of weight, and then
they lose
it
a
all
lot.
back.
Yeah.
For a role, you mean?
For a role.
Yeah. That's crazy.
Or even man versus woman. We see a lot better results sometimes in a man if he, drops his coffee creamer. And a woman, we can walk into Krispy Kreme and take a deep breath in and gain 5 pounds, right? So
So because of that, they look at other people and then they say, "Oh, you're cheating. You should."
Right.
And they have that. They're putting that onto them that they should be able to do what I can do.
Right.
If I can tell you, should be able to tell us. Just eat less and exercise more. Right. But we know there's just so many mechanisms, right, that are working against us with that, especially once you're there. Right. And so I think in the long 100-year plan, prevention, changing our, the food pyramid that we had for so long, all those kind of things. That's great for them, but a lot of us are here and now, and so we got to treat here and now.
And so with that, with genetics, let's talk a little bit about the role of our genes. Are there genes that are linked to obesity?
It's not so much specific genes. Yes, there are.
Okay.
Yes, there are. You're talking about MC4R resistance, right? And that, you miss those genes and nothing's going to work.
Right.
Right. And so there are some specific genes and specific syndromes and everything that you see. The problem is like if we can genetically test and everything, we don't know the penetrance of those genes, how much they're going to affect things, and all the other things that are involved as well. To give you an idea how complex, it can be, we had an old slide that I borrowed from one of our Harvard professors that came down, and they had basically the differential expression of genes in the greater curvature of stomach depending on a high-fat versus low-fat meal. About 50 different genes are turned on or turned off in response to that specific type of meal. Okay? Actually, it's more genes than that, and it goes about 50 different hormones.
Wow.
Right? So we usually talk about 3 or 4, that we have some grip on. Some of the folks in the basic science have a little bit more, but it's all a lot of contradictory stuff because you raise one up and another one, will either lower or come up higher to compensate for that. So while there's genetic, predisposition, and certainly that encodes our metabolism and stuff, we don't have it all nailed down to where we can genetically test it. And this is one of the things that'd be really nice and say who will do well with what surgery, who will do well with what medication.
Yes.
We'll still have that problem of knowing the penetrance of those, how that comes out phenotypically.
How it expresses in the body.
Right. So.
Yeah. Wow. Well, okay, so we've talked a little bit about the surgery options, the non-surgical options, the role of GLP-1s, and the genes. Tell me a little bit about, like, in your mind, you've done this for a long time. You've seen a lot of people. You've seen a lot of success, probably a lot of maybe regain over time.
A lot of challenges.
Yeah, right. Tell us, what's your favorite patient story?
Oh, gosh.
Do you have one?
There's a lot if I sit down and think about it. One that really comes to mind just because it was such a visual was we had a patient that I believe she was a nurse before, but she was a little older. Probably one of my older patients, 79.
Oh, wow.
I did her. I know, right?
I'm sorry. That reacted.
Did you think I could have my head examined for doing
No, I just think that
gastric bypass?
I think that's brave for a
79-year-old.
I think it's brave of her at 79 to say, all right, look, I've had enough.
Yeah.
Right.
So, you do that, and then, her parents lived over 100, so
Wow.
we
Get a lot of
clearly
years
had
left.
somebody that,
Yeah.
that had a long time to suffer potentially and everything. So we were able to get enough weight off her that she was able to have hips fixed and everything,
Wow.
and be able to get rid of a walker and those kind of things, and we were able to celebrate that with her. And
That's incredible.
She definitely has lived long enough to do well with that and reap the rewards.
Oh, that's wonderful. Yeah.
So
that's a great success story. What's the youngest patient you've...
Well, we do have an adolescent program.
Good, okay.
That I help out with.
I didn't know that, yeah.
That's the HEAL clinic.
Okay.
Yeah, so the healthy eating and active lifestyle clinic there at the Children's Hospital.
Oh,
And
good.
So,
Yeah.
the youngest you'll probably see there, don't quote me, I was probably 16 or so.
Okay.
We're very selective
Okay.
with those patients and everything, obviously, because you're trying to balance that risk,
Yes.
right? Which is actually, pretty small in the overall scheme of things. And
Right.
everything, but also you have to have a patient that can be compliant with things. And
Sure.
you're in an adolescent,
Yes.
time frame and
Oh,
everything.
yeah.
But you're also the time frame that if you can get weight off, get them healthier, think of how much more impact that has, at that age, that now a lot of things are open to you that weren't open. And,
Yes.
if you wait till later on after a lot of doors have closed for them, you've cut them off from some important things. So, I think, there's definitely going to be a role, and it is a role for the adolescent, but, it's, fewer and far between. So, so in our clinic, the lowest age is about 18. And a lot of those I will actually kind of interact with that HEAL clinic for them.
Sure.
And even up through 19, 20, because, some of us 19, 20, we're still kind of adolescents, right?
Oh, yeah, I raced
in a
a few
lot
of
of
those.
ways.
Oh, yeah.
Then at that age,
I'm in the thick of it.
they're still kids.
Yeah.
Yes.
Absolutely. So what do you see the future of obesity medicine? How do you see that changing as we move forward?
Well, the pipeline now with the enthusiasm there is going to be huge for these medications. And I haven't sat there and done all the, legwork on investigating the company to see what they have in the pipeline, but a lot more GLP-1s.
Right.
And as you know, the tirzepatide, is not just GLP. I mean, not just GLP-1, it's GIP also, right? So you're going to see a few more that may act on, additional, hormonal axes and stuff like that. I think that, over time, those will refine themselves a little bit. We'll get other ones coming in from other directions. I mean, it's always hard. Remember leptin?
Oh,
when leptin was it was like a big deal. I mean, they did the obese mice because they had the leptin knockout and everything. And so it was kind of like, okay, well, we're going to cure it because we found out that leptin is deficient, and we fix that, and then they lose their weight. Well, the number of people worldwide that were actually homozygous, so had true leptin deficiency and were obese because of that, was like a handful.
Yeah.
So we're going to come up against that in some of these discoveries and stuff too. But I think that what I alluded to a little bit earlier about being able to genetically test and then start targeting the therapies to that.
Oh, that'd be awesome.
I think that will be big and everything. So it's going to be a little hard because, again, you're going to have the patient, well, this test says this, but you're going to have so many other factors, that are involved in that too.
Absolutely.
So.
And you're right. It is, all these medicines have been groundbreaking. We've seen the positives definitely in our patients, but they're a tool in the toolbox of many things that could or could not work. And so it is very complex to make those decisions. So if we at our clinic or another provider that may be listening has a patient that may feel like they need to see you, how would they get to you?
Well, they can call, they can get referred. I'll just give the number now. It's 423-778-2906. Okay, so they can just call in. That's fine. They can go to the website. It's a great place to look. They can see some of the testimonials on there. They can get a link for the webinar, and they can watch our webinar. And I will say our webinar, we're in the process of redoing it, but I still am very fond of it. I mean, we literally, this setup is like, light years ahead of what we did. Right? So we had a laptop with the slides on it, and we literally all traded places and went through and did it. But that was the team we had that did that and everything. And it was good. Actually, we've been complimented sometimes that it was just because there wasn't overly produced and everything. So hopefully we'll come up with another one, which I'm sure we'll have no problems with overproduction. But it's very informative.
Absolutely.
It's probably close to an hour in length overall, maybe 45 minutes, but it's a little bit lengthy to get through. Or hopefully this next time we'll chop it up into smaller segments and everything. But it goes through why we have problems with obesity. What can we do about it? Of course, it goes through the surgery and everything, and we're introducing more of the medical options in there. But it'll give a good flavor for a lot of stuff that we have to offer.
What's the website for that?
You can just go to www.erlanger.org.
Okay.
And you should be able to get there.
Okay. Awesome.
Yeah, I'm pretty sure that Erlanger.com will actually take you to Erlanger, Kentucky.
Oh.
Yeah.
Don't want to go there.
Weird.
Yeah.
I didn't even know there was such.
There's an Erlanger.
Yeah.
There's a city called Erlanger, Kentucky. Sure enough.
Interesting. We'll learn all kinds of things here.
I know.
And I always love to ask my guests as we're wrapping it up, what are those 2 or 3 things in the world of obesity medicine that you would give advice to a patient who is on this, and we really all are on this journey. We all have different struggles. We all have different things we have to battle, whether it's lifestyle, genetics, hormones, What are the 2 or 3 pieces of advice that you would give someone in order to age well, live well, and to prevent some of these chronic conditions?
Right. Start early. Right. I mean, one of the biggest things that we've seen of talking to patients and everything, wish I would have done this early. And that could be medicine, that could be surgery, anything. Take action early. Don't keep waiting, for things, because as you're waiting, all those diseases are developing and they're progressing. And at some point, some of them get to points where you can't turn back and everything. Have realistic expectations, right? We're not going to de-age everybody back to 18 again or anything, So, I mean,
I don't want to be.
I know. In some ways, I'm glad about that. No.
we can kind of help out a little bit, right? I mean,
Sure.
you get people more mobile and stuff like that's going to feel a little bit like that, But it's not getting all the way back there. And obviously, I mean, I don't even have to tell our patients it's not about looks, right? I don't even have to tell our patients that really.
Sure.
They know, and they'll come and say it's not about that. I just want to be able
feel
to
better.
play with my grandkids. I want to be able to be there more for my family.
Yes.
Sometimes it was a specific one. I want to ride a roller coaster again, or something like that. And I think it's just normal experiences, that they had when they didn't have to wait and everything. So I think those are the big things early, do
Start
something early, and then obviously, have realistic expectations. Now, the expectations are one thing, but, where you get to, you may surpass your expectations and everything, but we have to be realistic in what we're dealing with. We're dealing with a really strong disease that's got a lot of things to address in it. And we talked about earlier a little bit, the ideal world, you eat less, you exercise more, you lose weight, and everything's great. In the real world, you got a job that demands you be there. Maybe you got overtime, maybe you got a move coming up, somebody with death in the family, a lot of stresses involved, and everything. You work the third shift and can't meal plan or whatever. So, you can cope with it. You could change jobs, but that's not practical, right? So, I try to look at, we got the ideal world, we got the real world, and then we have some practical solutions in between.
That's awesome. Well, this has been great. It's just really, I think, uncovered some other options for patients maybe that are out there and don't know what bariatric surgery is or what options may exist. And so thank you for joining us today.
Thanks for having me. It's been fun.
Yeah,
it's great. Thank you so much.
So until next time,